it's fun to translate immunology to English because you can get away with making up a lot of stuff on the podium and still sound important. But at the same time, it's actually fun to see eyes go, oh, yeah, that's what that is. So we'll see if we can make that work and have some fun along the way. I always dedicate these lectures to my dad, who passed away a couple years ago. He always used to tell me, slow down. So this is my reminder to myself to go slowly so I can make sure that everybody understands where we're going with this. These are some of my disclosures, which are a little bit relevant. My goal is to get you to see some of the markers of immunology and make them applicable to not only therapies, but also in terms of derm path, where staining is important. More important is to build the building blocks of a disease, match them to the derm path correlation, match them to therapies. So that'll be our goal for this whole thing. The other thing is to remind ourselves about how certain therapies impact the immune system, as well as how certain mechanisms can feedback on each other. We'll redefine some of these words that we tend to look at the other way, and then more importantly, just again, look at the immune mechanisms. So with that, we'll just describe this. No, maybe not. This is a little too, this is nystagmus and seizure-inducing. Looks more like the ski trails of Vail than it does an immune system. But you see the idea here. This is where a lot of things feed back on each other, and there's a lot of impact of how the immune system works together. And I'll show you from reality where some of these names and where these abbreviations actually make some sense. Okay? Now, these are some important abbreviations to remember. Okay? If you see all of these TH cell profiles, think of TH17 as the one we talk about most with psoriasis, right? TH1 is cellular immunity. TH2 is antibody or autoimmune-mediated immunity. All of these interleukins will have a role, and I'll show you again one by one where they have an impact not only on therapy, but also a lot of things we talk about as building blocks. Everyone has heard about cathelicidin, but we'll talk a little bit about what cathelicidins truly do and how we can mark for those. And then suppressor cells are going through a transformation of names. T regulatory cells, FOXP3 is a marker of those, and more importantly, where do they fit in tumors as well as an anti-inflammatory substrate. Now with that, think about how does the immune system work in the first place. It recognizes patterns, recognizes antigens. So we'll talk about some of these abbreviations, which are the ones that you see in different journals, and it makes you just want to rip the pages out. And then more importantly is something else as far as an immune processing like necroptosis and some of these inflammasomes that are markers in acne, and then more importantly in tumor recognition. So with that, take a very simple basic definition of immunity, which how we were basically trained many years ago or a generation ago. We divided humoral immunity, divided cellular immunity. Basically, intracellular pathogens versus extracellular pathogens were targets. Bacteria and parasites versus virus and tumors brought more cellular components. These were the effector cells. These are the ways we divided the T helper cell profile. These were the primary cytokines. These were some of the results or the effectors of those immune mechanisms. Now, a lot hasn't changed, but we need to add in this definition where TH17 is now being profiled as well as being characterized in psoriasis as well as some other epidermal turnover conditions. More importantly is you see where the primary cell line lies, and then more from there, we see a target. Now, in psoriasis, we don't think of an antigen or a target per se. We think more in terms of feedback and the way the cytokines behave, which I'll show you in a moment. And then these, again, are some of the cytokines that are at work. Now, these are important because, again, not in terms of staining, but also in terms of targets of therapy. And I'll show you the cascade of how all of these feed back on each other and where there's a division of how these profiles become, become their endpoint. And then, of course, these are the products and, again, some of the disease states which we talk about, right? Okay, good. I don't see anyone confused yet, but it's coming. Don't worry. All right. What is TH17 now in the profile? We hear about IL-17. We hear about these new drugs that impact IL-17. So what is IL-17, right? What does it actually mean? So the TH17 profile is a new way, again, of how we describe the T helper cells. There are subsets of interleukin 17. They upregulate interleukin 6. Interleukin 22 mediates epidermal hyperplasia. Interleukin 23 induces both of those, but independently of interleukin 12. Interferons in interleukin 4 inhibit those. So what the hell does that really mean? Okay. Think about interleukin 17 as its own actor, if you will, which is why it's a primary target for newer drugs like secukinumab and brodalumab and some of the other biologics that are coming. Interleukin 22 impacts the way that the epidermis turns over. Interleukin 23 modulates and induces both of those. Okay? Now, remember interleukin 4 was mentioned as its Th2 cytokine. It serves as a downregulator of both of those to keep that in check, except in disease states like psoriasis when that profile is so overwhelming, it's working somewhat independently. Okay? The point of this is to link the immune mechanisms to differentiation and the way that the skin turns over. Okay, we used to think of those separately. We used to think of psoriasis as kind of a sandwich of inflammation, epidermal turnover, and inflammation. Now we know that it's all bridged. Okay, so with that, here's this diagram, which you're going to hate me for even more. Okay, so let's walk through this. This is your immune system at rest. Okay, when things are not happening or when there's an abrupt, immediate consequence, you have recruitment of natural killer cells, tumor necrosis factor, interleukin 1, interleukin 6, they all activate dendritic cells. But what happens in a long-term process? You have the plasmacytoid dendritic cells, which are stored in the spleen as well as in the lymph nodes. You have myeloid, and the myeloid cells, which are swimming. Those originate from dormant macrophages. Okay? Now, think in terms again of activation. Interleukin 6 was thought to just activate and work with natural killer cells. Now we know that it also has an impact on differentiation. There's also an impact on these newer Janus kinase inhibitors, which are important for streaming and modulating the response, as well as some other proteins called MAP, and they work on a protein called GP130. Now all these numbers don't mean anything unless you understand where does this come in to make this process go forward. Okay, so divide it that way. But again, think in terms of what we do clinically. We work on inhibiting TNF. We work on inhibiting interleukin 17, which is, again, down here, but also starting up here. And more importantly, we try to basically steer the process and stop it in its tracks rather than working on symptoms, which are basically starting from down here. Okay, that's the difference really between treating the process and the disease. It's the result of the disease, if you will. Okay. Now, here's the dividing line where that activated macrophage has a destiny. It'll either be stimulated by interleukin 12, which will start to stimulate Th1 profile cells and create cellular immunity, or now that we're understanding where interleukin 23 comes in, it will create a profile of T helper cells that is more directed to epidermal turnover, what we call acanthosis, and from there, it has a destiny of stimulating keratinocytes in a different way. Okay. So that's where interleukin 17 and 22 come in, based on the action of 23 stimulating this T helper cell to make these cytokines work, and then promoting the change in differentiation of the keratinocytes. Okay? But you see here again, here's tumor necrosis factor, here's interleukin 17. These are targets of where we see the keratinocyte change progressing. Okay? That's where the therapies come in. That's also where we understand the feedback on these other cytokines. Again, tumor necrosis factor, S100, which we know is psoriasis, which is, again, an important epidermal marker. And then, of course, some of these other important interleukins like 8, which works on neutrophils, 10, which downregulates cellular immunity, and some of the other ones, which have a little bit less of an impact. Okay? All right, who needs a drink after that? Okay. But again, you see where everything builds together. There's a process that streams. There's also feedback, which again, from here, goes back to the beginning and starts this whole process over again, and that cascade can roll downhill if it's not interrupted. Okay? Again, this is in terms of psoriasis, but also we think about epidermal turnover and the way that differentiation is impacted by the immune system and vice versa. Okay? So now that it's football season, we'll just take a very simple approach of defining cytokines, okay? So think of interleukin 1 as the center, right? The center starts the play, right? We know that interleukin 1 is important for activating T cells, but I also mentioned some of those important interleukins, the important activities of interleukin 6. And interleukin 6 would kind of be like if there's a direct snap, and the center just takes the ball and sneaks through. So we'll build on that in a second. Interleukin 2, however, is kind of like the quarterback, right? It receives the ball, receives the message, starts the whole proliferation of effector T cells, but also, as we saw, it has an important impact on the destiny of those T cells, which for example would be like interleukin 4 would be a running back. It would basically carry the ball, right? Interleukin 5 would be like a wide receiver. and interleukin-6 would be like a tight end, for example, right? Again, these would carry out the plays. As we know, interleukin-4 works on mast cells. Interleukin-5 works on eosinophils. Interleukin-6, again, talks about some of those other processes. So the point is, there's starting the play, there's carrying out the play, there's affecting the play, okay? These are the cytokines that work together. Now, the game doesn't start without a kickoff, so interleukin-8 would be like the kickoff team, basically starting the play in motion, if you will. And if you remember, neutrophils are the first cell line that show up at most any immediate process, right? If you think about a pustule formation, you think about immediate recognition of antigen and the immediate effects. We know that interleukin-8 does most of that work and also starts chemotaxis, which basically brings in some of the other cell lines. Now, interleukin-10 is kind of like the defense. Okay, interleukin-10 promotes a Th2 response, works on B cells, works against cellular immunity. Okay, and then interleukin-12 is like the coach, sending in the next play to the center and the quarterback, but also modulating that entire process. But now we have interleukin-17 and these other ones. They may not fit in this football analogy, but at least we know that interleukin-1 and interleukin-17, as we saw from that other diagram, have very close linkage. Okay. All right, very good. So let's put some of this into reality, okay? Think of atopic dermatitis. Atopic dermatitis has these hallmarks. Interleukin-4, interleukin-5, interleukin-13 are very high levels. Interleukin-4 and 13 are the target of a newer monoclonal antibody biologic called dupilumab, okay? Interleukin-4 is also a target of lebrikizumab, which is another biologic. So finally, we may have biologics directed towards these targets of atopic dermatitis and changing that process, where we just used to think of these agents as for psoriasis, right? But they're directed towards that Th2 side and these important cytokines. And if you remember from any process, if you see mast cells, you start to see a reduction in cellular immunity, okay? So that's how, again, we change the process of eczema and not just think in terms of what we're seeing as far as symptoms. Now, psoriasis is different because we see higher levels of the CD4 counts. We see differences in interferon gamma profiles. It's more of an extrinsic process than an intrinsic process as far as our clinical screening. The point of that, again, is there's a very sharp line, but yet in terms of clinically, we don't think of everyone being exclusive, right? Is there a psoriasiform dermatitis? Can atopics get psoriasis? Right? We use these correlations clinically, and yet mechanistically it doesn't seem to make sense because they're on different sides of the immune fence. Okay? So that's the correlation we have to kind of keep in mind as we go along. Now, just in terms of the itch-scratch cycle, for example, we know that there's no receptor in the skin, like for pressure and temperature and some of the other things we feel, like Pacinian and Meissner corpuscles, for example. Itching is modulated by loose fibers, if you will, C and delta fibers specifically, and that's how we translate the itch sensation to our brains, right? Scratching can modulate and perpetuate that cycle, and that lichenification that ends up from that is where we see more structural change and less inflammatory change. And if you think about phosphodiesterase levels, those are important markers, or they used to be, in terms of where the itch-scratch cycle could have been measured, if you will. There's no way to assay for that. But you think about stimulation in terms of which cell lines are working forward. PDE4 now is being targeted by a drug called Apremilast, where we start to say, okay, are we working even further upstream to change the cytokine profile as well as the cellular profile of certain triggers that may change the benefit towards the patients who are chronically dealing with these diseases. And I'll show you where some of those case reports come towards the end. Now, again, neuropeptides have a significant role also in changing that itch-scratch cycle as well as perpetuating the inflammatory cascade. If you think of substance P, for example, is a very potent marker for a very potent trigger of pain, as well as it plays a very important role in urticaria by creating that wheel and flare response. It also has an important role in liberating histamine and allowing serotonin and histamine to have their impact. And if you think about patients who have renal failure or take opioids, that's where we tend to see a lot of their itching because the mast cells are then releasing and degranulating, and that free histamine is creating more itch. But also it's upregulated in patients with renal disease because their opioid receptors are also upregulated. So that's, again, part of that cycle of how we break itching. We can target some of these, like, for example, naloxone and naltrexone were thought to be used in uremic pruritus and have a role in breaking that cycle. Okay. Sorry about that. So, there was thought many years ago if atopic dermatitis was truly asthma of the skin, right? We use that correlation in patients. We think rhinitis, asthma, atopics, they're all connected in some ways because of the immune mechanisms. There was even talk of the atopic march, which was a very important concept in pediatric dermatology. But again, the mechanisms of all that come back to these foundations of mast cells, the way IgE behaves, and then a role of eosinophils, but also the hyperreactivity of the skin, right? This is a foundation of atopics where they get triggered they get a flare from very basic triggers. And just like the same way with asthma and allergic rhinitis, we see that same concept. Okay, so again, just thinking in terms of the acute phase of atopic dermatitis, you see higher levels of interleukin-4, you see recruitment of T cells, very, very low amounts of eosinophils, and if you have to same for basophils and neutrophils, versus in the chronic stages and more like in simplex stages, you have higher levels of interleukin-5 working to stimulate more populations of eosinophils, you have more mast cells, and then an overall Th2 pattern can actually give way to a little bit of a Th1 side where you see that cellular balance shifting. Okay, and again, this is where we see more structural change and less inflammation change. All right, let's switch gears a little bit about toll-like receptors. Toll-like receptors, again, are a major part of our innate immune response. Okay, they're recruited for a reason. They're recruited to survey for a process, and more importantly, they are pattern recognition receptors. Pattern recognitions or pathogen-associated molecular receptors are shortened for PAMPs. These are concerned, and they're looking for more like antigen. And the simple way to think about it is PAMPs are looking for antigen, and then there's another receptor or another pattern called danger-associated patterns, which are DAMPs, and they're looking for streaming patterns, which is like what we look at with P. acnes, for example. Okay, so in humans we have toll-like receptors 1 to 10. We're also seeing more and more of those, and then again, these have impact on not only pathogen recognition but also the impact on differentiation. So let's study this chart for a second. You see toll-like receptor 3, 4, 5, and 9. These are just examples of toll-like receptors that actually have an impact on all of these components of upregulation and activation of adhesion molecules, but also promotion of differentiation. So again, look at the impact of tumor necrosis factor, of interleukin-8, of some of these other CD markers like type 1 interferon, and then of course NF-kappa beta, which is an important neurotransmitter. They all have some linkage and some connection to the way that these toll-like receptors work. Okay, this is where we bridge, again, not only in terms of antigen recognition, but also in terms of the impact on the epidermis, on promotion of differentiation, and more importantly, you see the balancing act between all of those important markers. Now, where is this important? Think in terms of wound healing, think in terms of psoriasis, think in terms of anything that involves epidermal turnover. They all feed back on each other. In terms of toll-like receptor 4, which we know has as basically lipopolysaccharide as its marker, this could be targets for different kinds of therapies as well as different antibiotics, for example. Okay, so the connection between those is, again, changing the process of the disease and how it's built as well as how it progresses. Okay, now this is how we make an immune response, and I borrowed this from an old imiquimod slide deck. But the point of this is recognition of antigen, processing that antigen, breaking it down from a neurotransmitter by phosphorylating it. When that goes from the cytoplasm into the nucleus, that NF-kappa beta neurotransmitter promotes the way that it's transcribed, the way that translation occurs, and then, of course, the way the cytokines are made that are appropriate for this antigen. Okay? This is the specificity of how we make cytokines towards the target. Okay? All that is processed. But within all of these components are, again, targets for different therapies, right? They're also targets of staining, if you will, the way that we look for the way that these processes are promoted. Okay? Now, there was let's go back here for a second. MYD88 is the neurotransmitter here that gets the signaling that then is cleaved and makes NF-kappa beta. Okay. Now, what's important to remember about MYD88 is it has a very close linkage to another marker called CD14, which is, again, looking for lipopolysaccharide. This is how different bacteria are surveyed by toll-like receptors as antigen. Okay. So if there's lipopolysaccharide on a bacterial capsule, these components are searching for that, And if you think in terms of how antibiotics might work, they might be suppressing some of that activity. Okay, MYD88 is also an important linkage of toll-like receptor 4, as mentioned, because of its linkage here. And toll-like receptor 4 is that signaling receptor. Okay, so think of the way certain antibiotics work. Think of the way that they're targeting different antigen. That's how all of that comes into relevance. Okay. Now, FOXP3, as I mentioned before, is part of the T regulatory line. It's part of a suppressor cell line of lymphocytes. And where we're seeing it most is in squamous cell carcinoma, where we're seeing in downregulating immune response. We get a lot of discussion of the role of FOXP3. The point of that is, excuse me, it's considered, again, suppressing this line. And many would consider TH3 as the T suppressor line of T helper cells. Okay? Now, where that's important is, for example, again, I'll skip through this, it's a little complicated. We're looking at the way that immunosuppression is made by the interactions between transforming growth factor beta and interleukin 10, which again, like I showed you before, suppress an immune response. And again, what's happening is they may surround a squamous cell and almost create like a little defense for it, right? And that's where we try to use immune response modifiers, interferons, and some of those pro-T cellular response or agents to undo the effect of what we see with the way that the FOXP3 marks T suppressor cells protect the squamous cell from the immune system. Okay. Now, what are defenses? Defensins are part of that whole arena where some of them are innate, some of them are induced. The point of that is they have interactions with interleukin 1 and NF-kappa beta also. Okay. Human body defensin 2 and 4 are inducible by these two markers, by interleukin 1, and 1 and 3 are basically constituent. They're always expressed. Okay. Now, where that's important is the way that cathelicidins come together in terms of not only wound healing, but as I mentioned about psoriasis, we'll also see in terms of acne and rosacea, they all come together to make the activity of cathelicidins more accelerated. So just imagine, take for example, if you cut yourself, right? You bleed a little bit, you see some granulation tissue, you might see some purulence or some exudate. All of that is modulated by the effect of cathelicidins, right? And what happens is they serve an indirect response based on the cytokine release by promotion of angiogenesis and by helping to re-epithelialize or reproduce that epidermis that's been damaged, right? Now, if antimicrobial peptides, in terms of their activity if that's unregulated, that's going to create all of these effects to roll downhill, and those of inflammatory effects are going to be harmful. Okay. Now, you may hear a lot of different abbreviations. LL37 is the name of the active human cathelicidin. Okay, we stain for LL37 to see its upregulation as well as the population of how much recruitment, for example. It's cleaved from a protein called HCAP18. There are subsets called RK31, SK30, LL25, which are more dormant. And there's a stimulating protein called kallikrein-5, which lives in the stratum corneum. Okay. Now, again, all of these agents are fed on or are promoted by matrix metalloproteinases, by different injuries, by different triggering processes. Kallikrein-5 basically triggers the activity of LL37, and that's the effector part of cathelicidin that does the work. Now, if you're confused already, what you'll see even more is some of the new linkage where vitamin D actually has a little response element on LL37, and it can induce its activity in keratinocytes that are basically considered immortalized, right? So think back to the last patient you used topical vitamin D in, or what was one of the knocks about topical vitamin D? People would say it doesn't work. Well, vitamin D topically is not meant to work or do one process. It's meant to modulate and change differentiation over time, right? So the point of this is saying, okay, if vitamin D is doing something to cathelicidin, it's re-promoting normal differentiation, we're not going to see those effects quickly. We're going to see those effects over a year's time, over 5 years' time, right? So it's meant to keep things in check rather than treat something that's acute. And the reason for that is the way that these interactions occur to change differentiation as well as to reduce local immunity, or local immune responses, if you will. Now, if you think in terms of toll-like receptor 2, its activity also is linked to vitamin D induced expression of LO37. So there's a feedback of all of those components, and where that's important is in acne, right? Because again, toll-like receptor 2 is surveying for P. acnes as well as it's being suppressed by retinoids, and what's more important there is the activation of LO37 in the pilosebaceous unit. Now, LO37 is also a very important chemoattractant for neutrophils and other T cell lines. And then the flip side is that mast cells can induce peptides that also produce LO37. So it kind of plays on both sides, right? Because mast cells are more of a Th2 cytokine or Th2 cell, and what we're looking for with these is more Th1 immunity. So LO37 is very nonspecific in the way it behaves. Okay. And we always hear about, the difference. Like people say, well, cathelicidins, cytokines, I mean, which circulates and which does what? Again, cytokines are doing their job locally after being recruited. Cathelicidins are part of innate immunity that's recruited when there's a trigger. Okay, that's the difference. Because cathelicidins don't circulate; they basically work, and then they're basically broken down from there. Now, again, I mentioned about wound healing. Think about a wound where it's basically abrupt or very acute. Keratinocytes will start to work around a wound. You'll see an increased expression of CD14 as well as those toll-like receptor 2 genes that I mentioned. You'll see an overall increase in cathelicidin level of LO37. And those same genes that are induced by that vitamin D response element, they will go back and start that cascade over again. So again, it's showing where vitamin D fits, but also in terms of where is vitamin D's purpose in that whole cascade. Okay, so again, if you link that to psoriasis, we'll say cathelicidins initiate a host response. Then in psoriasis specifically, they're blocking those cathelicidin pathways, breaking that entire cycle. And then again, as I mentioned here, vitamin D targets cathelicidin genes by its own response element. Okay, so again, kind of redefines to us what is vitamin D actually doing, right? When we think, okay, well, I put topical vitamin D on, it didn't work. Well, again, you're not going to see that acute effect. Chronic or repetitive use of vitamin D will change the way that whole process is working, not just in terms of reinstituting normal differentiation, but also, as we're seeing here, the way that immune recruitment is impacting the process. Okay? So again, I mentioned that sandwich concept. I mean, this is the way many of us were taught, right? We saw, stratum corneum full of neutrophils, the microabscesses throughout here. You see epidermal hyperplasia. You see all of this, inflammation swimming. We now know that all of this is built together, right? All of this is filled with tumor necrosis factor. We saw interleukin 17 and where that's fitting into the cascade, where that's impacting differentiation. So again, it's all linked together means that it can all be affected together, right? That these are the targets of our biologics. These are the targets of our topical therapies. And this is where, again, vitamin D can not just impact, this component, but it's also affecting all of this inflammation, right? And again, if you look through here, for example, here's the upregulation of cathelicidin. This is upregulation of the defensin 2, defensin 3, which is constitutive. This is induced. And then this is S100 through here. You see these other components of interleukin 17 and interleukin 8. This is all in untreated skin, right? This is after several months of the use of calcipotriol on the skin. You see now that whole component has shifted except for the normal expression of cathelicidin, right? Modulating the entire process and keeping it regular. But now these immune markers have all flipped, right? Basically over time. This is not the effect of steroids or an abrupt change from biologics. This is changing the entire process based on the impact of vitamin D. Okay? Now, again, many of us were confused too in the way when we were treating psoriasis or treating diseases of epidermal hyperplasia where, we were thinking that retinoids and vitamin D had catalytic effects. And the truth of the matter is they don't. They are more important for not only immune modulation between those neurotransmitters, as we talked about, but also decreasing the population of these cytokines and repurposing differentiation so that it can be steady and more uniform, right? And again, vitamin D receptors are everywhere. They're on lymphocytes. They're on all of those other cells. Just like keratinocytes are dendritic cells and secrete interleukin 1, so are these other cells that display vitamin D receptors. And as we just saw, the vitamin D impacts LO37 and it impacts toll-like receptor 2. So again, we're thinking in terms of what happens in acne, what happens in infections, what happens in wound healing. They all have significant interactions based on the way vitamin D works, as well as the way the cathelicidins interact with them. Now, vitamin D analogs, they come in different flavors, for example. This is, the impact on those. Calcitriol is the natural form. It has a very significant impact on transcription, on all of these other neurotransmitters, as I mentioned. Calcipotriene is the synthetic version. It has the same binding capacity to the vitamin D receptor, but the exertion of the receptor and vitamin D complex is about 100 times less potent with the synthetic version than with the natural version. So they bind equally, but it's what they do in the bound complex is what makes the difference. Okay? Now, where is that relevant? Well, again, think in terms of like morphea, for example, where you see some of these case reports, they tried 1 month and 3 months. Morphea is not a condition we would treat for 3 months, right? We would want to see the impact for like 5 years and see what happens to that patient. But again, the differentiation change would probably be good for saving, unnecessary use of steroids or maybe something else that we might try that might be more noxious. So we think in terms of maintenance where vitamin D might have its impact. And this is, again, where oral vitamin D was tried in a placebo trial and really didn't have much impact. They also tried it in patients with linear scleroderma, and there really wasn't much seen. But again, this has to be done for a year, for 3 years at a time to really see some sort of difference, right? Now, I'll just finish up with inflammasomes. Inflammasomes are newly characterized components in basically processing. And the nod-like receptor, the NLRs, have a significant role in acne in terms of looking and surveying for P. acnes as well as processing the entire immune response of acne. Now, this was published a couple of years ago, and I always thought this was very interesting because it redefined what we think in terms of cellular responses and cell death as well as target death. And apoptosis is where you have those death enzymes, the caspases. They're working to create cell death that's regulated, as well as when apoptosis is out of control, it's working by degrading with very little antigen exposed to the immune system, to the immune mechanisms. Necroptosis is different. The caspases are inactive, but there's still cell death using what we call these RIP kinases. And they start to signal an entire different pathway, right? And I mentioned before about the danger-associated patterns, the DAMPs. These are inside the cells versus the pattern, the pathogen patterns, or the PAMPs. Those are the ones on the cell membranes. Okay, so toll-like receptors are an example of PAMPs, and these nod receptors are an example of DAMPs. This is, again, the way that in the inflammatory components of acne, the DAMPs are actually looking for patterns that P. acnes leaves behind, kind of like a wake from a boat. It's looking for different patterns that it can recognize, versus toll-like receptors are actually looking for antigen and one pure target. Okay, so again, these are different targets of our immune system that could be pharmacologic down the road, as well as the way that we think about the impact or the components of where the immune system can be broken down. So, again, the NOD receptors are broken down into NOD1, which binds the ligand of P. acnes, and the NOD2 receptors triggering the cytokine responses that are appropriate for it. Okay? And then again, like toll-like receptors, as I showed you, toll-like receptor 2 has a lot to do with looking at the activity of P. acnes and some of the other components of acne. Retinoids have a significant inhibitory effect of the expression of toll-like receptor 2, and as we mentioned before, toll-like receptor 4 is linked to lipopolysaccharide and other peptidoglycans. Okay, but it all again starts with interleukin 1. Interleukin 1 is in the keratinocytes. It's already upregulating. It's stimulating the microcomedone process, and it has a significant feedback on the destiny of where a microcomedone may end up, whether it be in terms of a papule versus an open comedone. These have the role of basically starting the process in motion. And if you look at through here, for example, here's interleukin 1, some of those antimicrobial peptides we mentioned. These are some of the dendritic cells that are displaying toll-like receptor 2, going after P. acnes, which is doing its damage job through here. All of that inflammation is being recruited. You have neutrophils, which are the bowling balls here, and then you have the larger grapes, which are other lymphocytes that are recruited also to break down the pilosebaceous unit. You see the feedback between all of those, but you also see where some of that tissue destruction can be broken or can be prevented by certain targets, and especially like we talked about with retinoids, they're a target or they're working on the activity of toll-like receptor 2. So it, again, brings us the understanding that retinoids are not just for changing differentiation, they have significant anti-inflammatory activity. And again, this is where staining of the toll-like receptor 2 gives us some breakdown. So again, why does acne leave scars? You know, you think of inflammation impairing the wound healing unit. You think of, you know, the balance between lymphocytes and dendritic cells. This is where, again, P. acnes can start that process, but eventually it's the immune profiling or the immune mechanisms that will break some of that down. And if you want to characterize it simply, it's the ratio between dendritic cells and macrophages versus lymphocytes that is more evident in scarring. And this is a schematic that Dr. Kang gave me that he was working on. You see these two pathways or two destinies that can promote scarring, either the role of interleukin-1 or the role of tumor necrosis factor through here. You see the impact on these two neurotransmitters, NF-kappa beta and AP1. AP1 works by working on some of these matrix metalloproteinases like MMP2, MMP9, MMP1. These are all elastases and gelatinases that break down the dermal stroma. From there, you see the breakdown of the dermal matrix through here. If you go the other way and follow the NF-kappa beta process, it's working on promoting the activity of interleukin-1, of tumor necrosis factor, and interleukin-8. We already saw what these cytokines can do in terms of promoting neutrophils in the other cell lines, especially as MMP8, which is a collagenase. From there, you see how basically the dermis is broken down and how that scarring cascade is promoted, right? Now, again, there are a lot of different cathelicidin lines in acne. There's LL37, as we talked about, that's made by human sebocytes. We also know that when we think about MMP1 and MMP9, these are overly expressed in inflammatory acne, and P. acnes induces those two cytokines, which again can also be, you know, a target for what retinoids do. So again, goes back to the role of retinoids, not just saying they work on differentiation or the comedone, but also the impact on inflammation. And then again, this is again with rosacea. We don't have a target in rosacea, but we also change the way that these balances go along in terms of neutrophils and reactive oxygen species. Give me 5 more minutes? One more minute. Okay. Then I will give you the last part of this, which we already talked about through here, and I'll just show you this last schematic of retinoids through there. And then this is the blockade of AP1, and then in breakdown of those cytokines. And this reference is in your handout, so I won't go over it through here. I'm just going to skip over some of this, and I'll again go back to some of these correlations to you. So if we see, you know, the role of acitretin in T-cell lymphoma, for example, we're seeing where these may have some impact down the road. Again, this is changing the way that the tumors and the way that differentiation change can be progressed. I already mentioned about Apremilast. I'm talking about phosphodiesterase 4. And this is the pathway of phosphodiesterase 4. Through here, you see decrease in the overall activity of cyclic AMP, changes the way that protein kinase A can impact those neurotransmitters. You see downregulation of those cytokines, and then, of course, the CREB-mediated production of those anti-inflammatory proteins. This protein, by the way, is what distinguishes Apremilast from those older drugs that were thalidomide analogs. So it's important to recognize that Apremilast is not linked to thalidomide, doesn't work the same way, but it does have that impact on that same cytokine profile.